Actually, I'll be talking about, the title is Neuromuscular Orthodontics, Grounded in a Novel Neurobiological Paradigm of the Human Body, Delineates treatment objectives distinct from those of traditional orthodontics. I'd like to thank Professor Marian Constantinescu, Simona, and all the other doctors that are helping out this fantastic InnoBioDent 2023, which is unites several participants from all over the world. You can see from this first page here, I'm a member of ICMO, International College of Craniomandibular Orthopedics. Right here is the logo of the university in which I am director of a mastership in neuromuscular orthodontics, in which fantastic doctors that you already met, like Prabhu Raman, Ida Shapira, Stanislav Blum, Florin Constantinescu, are all members and teachers of. I am a member of the European Respiratory Society because every orthodontist now is integrated into understanding breathing at a much higher level. So let's go forward to see if it works. I've been working for the last 30 years trying to create a new methodology in orthodontics, which is the application of the neuromuscular principles to orthodontics. This said, this year in 2023, I came out with my book, which is from Springer. It just came out in November. And what I'll be talking about today is partially from this book. I do not receive any royalties, so if you buy the book or don't buy it, it won't change my economic status. When I first started the neuromuscular in orthodontics, I thought that it was not that far away from traditional orthodontics. I thought that traditional orthodontics that had been brought all the way to the 1980s was at such a level that probably it was very close to what I could have found when I was doing diagnostics, when I started doing diagnostics to my patients in the late 80s and beginning of the 90s. Well, I have to retreat on that. I have to say that actually the difference is very, very big. And now I think that neuromuscular orthodontics should be considered and distinguished, a distinguished specialty in orthodontics. Of course, neuromuscular orthodontists and neuromuscular dentists are very few in the world. So were those that thought that the world was round when the whole world was thinking that the world was flat. So we're just a little small number, and we are quite convinced that we're doing right, you know? And that is the most painful thing for who believes in neuromuscular orthodontics and has proved in 30 years of his own practice of the results. Now, you just saw, for example, a clinical case from Prabhu Raman, which is fantastic, which of course is beautiful from a dental point of view, and you know, the teeth are very well designed and things like that. But the most important aspect that neuromuscular dentists do is change the mandibular position according to the physiological needs of the individual. Now, I think the change is revolutionary. So yes, it's a revolution. And it's a change that has to be understood and has to be delivered to the widest audience possible. And this is one of the reasons why I wrote the book, and one of the reasons that has brought me to push for a master's in neuromuscular orthodontics. Now, there are big differences between traditional orthodontics and neuromuscular orthodontics. First of all, with traditional, you're used to using cephalometrics, and you consider the mandibular arch, at least that was taught to me, as a guide to create occlusion. And clinical assessment is subjective. That it means you do a lot of muscle palpation, you look at swallow, you listen to TMJ noises, you kind of look at mandibular movements and and patterns of mastication. In neuromuscular orthodontics, we don't use cephalometrics too much. We do study arch position, but it is considered a guide only when we do a mandibular recording, okay? And as you've seen already with other neuromuscular dentists who have been lecturing on InnoBioDent, this mandibular position is considered guide when it is obtained through relaxing of the muscles where the mandibular arch position, the mandibular position is not linked to occlusion. And this is obtained using a TENS device. Clinical assessment is objective. We do not only look at swallow, but we want to record it with electromyography and study muscles this way. We want to listen to TMJ noises, but we want to analyze them on the computer with a system analysis. And we want to use jaw tracking to see mandibular movements. But most importantly, we want to see EMG muscle function together with mandibular movements, because alone, that information is usually not sufficient for a lot of occlusal diagnostics. So what will I be talking to you today? I'll be talking about a neurobiological model of the human body, which is the most important part of my presentation today. And I'll be talking about structural characteristics of specific morphological types that do limit our ideal function, what we tend to find, okay? And I'll be talking to you about what the treatment objectives in neuromuscular orthodontics and how this neurobiological model of the human body, which is a new way to conceive anatomy and functional anatomy, applies to neuromuscular orthodontic with a clinical case. Okay, so first of all, I want to talk a little bit about fascia. I know most of you are very deep into fascia, but fascia is actually everywhere in our body. When I was studying anatomy, we were taught that muscles and soft tissues were like laid as drapes on the skeleton, and that the activity of the muscles will give tone and posture. Well, since then, there have been big changes in the study of anatomy. Knowing better fascia, this connective tissue that is all over, changes in a way this idea of the drape we had, okay? Then at one point, the idea that was presented as an engineering and architectural philosophy called tensegrity, and here you can see an example of tensegrity. You can see just wires and metal tubes here that create a self-standing piece of art without any cement that holds the parts together. And this is called tensegrity. This is an example of tensegrity. And where there are islands of compression in a balanced sea of tensional components. So the compressional components here would be those metal tubes, and the tensional components would be the wires. And this is a beautiful piece of art, and it just stands there, but there's no cement, no link, no glue between the parts you see. And this idea has been brought to the human body, where fascia and muscles are the tensional components, and bones are the compressional components. Okay. And Stephan Levin, of course, wrote, you should read these books, are very, very interesting. And there are we have already several models of human parts that describe how and why the human body functions in a different way than just a muscle moving an arm. We are kind of linked to the idea of single components of the body, like you can take away when we build. Like the movement of an arm is the movement of an arm, and we consider the arm as one anatomical component, and the movement exactly linked to that anatomical component. Well, actually, this is a new way of seeking truth and to justify a lot of things that were not and are still not conceivable of the human body as it functions, with this new idea, this new morphological functional aspect of the human body is now presented, is now a way to explain how the human body works in all its fascinating ways. Let me give you an example. You've probably seen backlifts of about 400 and 500 kilos. How can that happen and without a leg exploding under this enormous pressure? Okay, all these examples, or hand wrestling with over 180 pounds of pressure, not break every single part of your body and not break your arm or your joint. All these functions are linked to a new model that considers a whole structure and not the single anatomical components, the single components of independent chains of function. Actually, it's a kinematic chain, and chains are interlinked in each other, and pressure and function and work is distributed along a network of anatomical components. This changes immediately the idea and the comprehension of what would be joint load during mastication. When we compress our teeth or bite on hard something, we consider, we've been talking for so many years about, oh, this loads the joint, and this brings a problem to the joint that in years will then destroy the joint itself. Well, actually, we know now from this neurobiological model and the biotensegrity model that this doesn't actually happen. If there's a balanced muscular function, there is no direct condylar load, okay? This and other smaller and wider examples of anatomical components up to the cell, okay, as a single component, all deliver together this new understanding of how the human body works. Now, under this model, of course, which is a real holistic model, this is the real meaning of holistic. Holistic is not supposed to mean anything that is incomprehensible from a classical medical point of view. It has nothing to do with that. Holistic comes from the word whole. That means trying to understand the whole body as a whole and not single components. And going back to the joints, then we can start saying that if there is a degenerative hard tissue reaction and disease in the joint, it is the result of unbalanced function, okay? And it can be due to anatomical damage. That is, we have a severe malocclusion, for example, and this creates actually a real load in the joint, as example, loss of teeth or fractures and post-traumatic fractures, et cetera, et cetera. So anatomical damage is important in this aspect, but also the morphological traits. For example, long face syndromes tend to have more frequent arthrosis through TMJ than any other anatomical morphological trait. So at this point, we can say that yes, we should try our best to work and find an ideal function, an ideal occlusion, an ideal function, but we have only these two limits on our sides, which are the morphological limits, which are anatomical, which are something that we cannot change if we don't change it with surgery. And sometimes not even surgery can really change a morphological trait. So the degenerative reactions are the result of necessary functions that are imposed where there is an insufficient tissue resistance. That means we go over a structural tolerance of an individual. So we get these degenerative reactions there. And when we consider at the end of all this discussion what this model is giving to the interpretation of the human body, structure and function are not complete distinct entities. That means we will not talk anymore about movement of the arm, but we'll talk about a movement of the complex that is between arm and shoulder and back and posture of the human body. So it makes things a little bit more complicated because we're used to separating and creating little notches of knowledge and having them all there packed, and it makes things easier for us because we're used to dividing. But now we have to see things in a much wider perspective and apply this in a much more wider way. First of all, when we go back to the fascia, this is from Dr. Schlepp, Fascial Plasticity in 2003. We can see that the most abundant interfascial mechanoceptors are type 3 and 4. And put all together, all these receptors, they make the largest sensory organ of the human body to send information to the central nervous system. So we've been, forgetting fascia when we were studying anatomy in medical school, and now it turns out to be the most important, component, central component to the central nervous system. Wow, that's pretty important. So when we use a TENS device or we want to relax muscles, it's not only the muscles we're working on, but it's also the mechanoceptors that are present and provide detailed information that come from all the tissues that surround the muscles. Like when we're looking at the temporalis, the masseter, and the infraoid muscles for the mandibular position. Okay. And the central nervous system elaborates an enormous quantity of information and is able to fine-tune a muscular reaction, because the central nervous system only acts through muscle activation directly. And if we want to consider this response in its smallest and most selective entity, it can be considered as a single motor unit, okay? So this is what we use to relax muscles. Of course, we have the Golgi, and probably it could be that the J5, the TENS, works on the Golgi receptors as well. This has been hypothesized, and it probably could be. And also, this participates to the immediate reaction we have in muscles that start to relax. Now, focusing on this neurobiological model, we have all the systems that participate in giving the overall health. And you can probably imagine all these systems linked also together, and how a reduction of function, of optimal function of one of these systems can influence the others. Okay. And this is the publication I'm talking to you about, which is very interesting, from Robert Schleck, and it's also cited in my book. And so we have to then apply this new model, okay, this modern way of seeing anatomy, of looking at anatomy, and we have to apply this to orthodontic treatment. Okay, so this is the characteristic of neuromuscular orthodontic treatment. And so first of all, we have to correct the structure, because I talked to you about the morphological limits. Whenever we can, we have to correct them, because if they don't give enough space to deploy a correct function, we will never get a satisfactory result. So obviously, the correction of function is very important. Okay. Then we have to reduce the orthodontic force we apply, okay? The quantity, okay, of force we apply. Because to every action, we have a reaction. Well, us orthodontists learn immediately that if we try to move teeth with too much pressure, we get a reaction from the tissues that make the yellow tissue that reduces tooth movement and can even block tooth movement. And we know that if we apply small, gentle, light, continuous forces, we can move teeth in several directions without having any type of strong reaction from the tissues. So that is a quantitative aspect, and it's a reduction of the quantitative part. Then the treatment should be an interaction. And that means that the direction, okay, we talked about the quantity, the direction on which we apply forces has to be physiological, has to be what function requires, and most of all, what development requires. Okay, so if we're working if the growth is face forward, okay, in practical, anything that we do face backward is wrong from this point of view. We have to reduce reaction, and this is also done deploying our forces in the correct manner that will not be against development. Okay, this is very important because, for example, for those who are orthodontists that understand this, the correction of the occlusal plane, can have a anti-rotation or rotation aspect, clockwise or counterclockwise rotation aspect. And this is very important because the counterclockwise rotation is physiological. The clockwise rotation of the occlusal plane is not physiological. So this should then, whenever done correctly, should enhance a positive physiological response to treatment. Osteopath learned before medical doctors of the concept of the auto-healing capabilities of the human body. It's the same whenever we apply treatment to someone. Sometimes all you need is, to have health is to give that individual a little push, okay? Not to push him hard or to treat him with too many and excessive treatments. And that determination of the direction in which we apply treatment should favor a mandibular position that we already see during spontaneous deglutition. Okay, and I'll give you an example of this new concept with a clinical case.
In fact, Willy Wonka did the first candy. In fact, Willy Wonka.
So you saw the kid with all the extraoral traction and the force applied for orthodontic treatment. Well, actually, that treatment you saw there is not really that far from what I saw in the late 80s, okay? Now, morphology limits ideal function. That means that, let me give you an example. If we have a long face syndrome, that long face syndrome will always have problems. The anatomy of the mandible, the condyle, the glenoid fossa, they all send a very straightforward message in which their range of anatomical tolerance is very reduced. There is no freeway space in these individuals, and they tend to have a straight neck. So they're already very good candidates for that degeneration of the joints we were talking about, okay? And actually, there are no cases I've seen in 40 years in which very open-bite individuals that did not undergo surgery for correction have degenerative joint disease, okay? Now, it varies from mild to moderate to severe, but it's always there, okay? The ideal stomatognatic function for this reason is limited to, let's say, the center of the Gaussian bell of the individuals that are in the norm, which skeletally, morphologically are considered the norm. We have a lot of treatment, a lot of treatment variables we can apply on these subjects to guide them to the end of growth to a perfect occlusion, or treat adults and have them with a balanced final occlusion, which can be considered more or less ideal. And we can't have this in other variables in which we cannot, and we try not to, and we cannot correct that structural intolerance that is going to be present, okay? Let me give you another example. For example, if we have upper maxillaris tight like this, we will never have a correct swallow. There's no way. If we don't correct, okay, the transverse discrepancy, the bone of the maxilla, we'll never have a correct swallow. We don't have a correct swallow, we cannot have a correct occlusion. So since one of our goals is an ideal centric that us neuromuscular guys call myocentric, this can be granted in certain cases, probably not in all. In certain cases, only after a surgical structural correction. Now, what are the treatment objectives that we have? So in the classical orthodontics, you'd have a class 1 occlusion with the 6 keys of Andrews, keys of occlusion. We have to reduce the overjet, improve all cephalometric measurements, like if cephalometrics would give a normal function, but it's not like that. It's not. It's more considered important in tooth movement and less a mandibular position. In neuromuscular orthodontics, we reduce muscle accommodation, we establish a correct swallow pattern, we want to preserve TMJ function, and a class 1 dental occlusion is only when it's possible and it's left to the ability of the practitioner. It's less tooth movement probably and more mandibular reposition. So I'll give you an example case so I can show you how these principles apply to a clinical case. This girl, date of birth is 2009. She came in 2020. She had a medical history where she was, operated for a dentinotensilectomy, and the mom saw misaligned teeth, and she might look like a tired little girl, but now she's very smart and very awake. And if you take a look at this lateral ceph X-ray, you'll notice that there is a clear tendency to a slight open bite, okay? But we are neuromuscular orthodontists, so we like to measure if there's freeway space. When I see a neck like that, I think that probably there is still some freeway space. So this is just for fun. So those of you who love cephalometrics can take a look at this and do their diagnostics. And this is just to confirm this slight tendency to class 3 and the slight tendency to open bite. This is what we'd see at the beginning, and I want you to note the lower arch, there is really no space for the incisors and the canines. And so now what we do first, we have to remember that our first move is the correction of strut, okay? Then reduce the force of interaction, and then interaction according to the direction of development of the individual. And correction of the transverse discrepancy of the maxilla. We do this with rapid palatal expansion, obviously. So we apply also a lingual arch on the lower arch. But as we do this, we'll be applying class 3 elastics on a lip bumper to slightly tip and distalize the lower arch during treatment. Because in jargon, we have what we call a front wall here, okay? So whenever we distalize teeth on the lower arch, we are moving the condyle forward and downward. That is exactly what this malocclusion is asking us. The rotation of the occlusal plane is counterclockwise, which is the natural direction of the development during development growth of the individual of the occlusal plane. We want to reduce this force of action. We really don't need big, strong, powerful wires. You can see up here and here that we start to distalize the lower fives as we create more space. this gives us the possibility of aligning the lower arch and reducing the curve of speed. Okay, and this treatment should also be interactive. That means we have to reduce a reaction. To reduce a reaction, we want to use constant forces that are applied without the creation of any response, strong response from the tissues. So what we're doing here, we're waiting for the canines, we're opening the upper arch, we're just aligning the upper arch. We already expanded it with the rapid palatal expander. Now we're correcting slightly and slowly the torque of the upper arch, and this will create space for the canine. And the wires we are using are night-type thermal wires, which are very soft, okay? And of course, if I have diagnosed that we had a front wall, and from a neuromuscular perspective, this means that the mandible will come forward. And if it comes forward, while we correct freeway space, there's really no need for any inter-arch elastics for this, okay? And this is exactly what happened. As we correct the upper arch, we extrude the premolar section, we determine what I call mandibular freedom, which is key, and that just repositions the mandible easily. And this case is obviously finished, it's beautiful, and it was very easy. And it was easy because we applied the basic neuromuscular principles which were correct the structure with rapid palatal expansion, upper arch alignment, give mandibular freedom to the lower arch, and distalize the lower arch if possible, okay? And then apply the fixed appliance to the lower arch as late as possible. And that's exactly what we did. And then we did the mid-lower extrusion without compromising incisal torque. This is what we get at the end of our treatment. You can see it here on the right, excuse me, on the right. This is what we see. When we like to measure, so we'll do kinesiography and test all this. And this is exactly what I'm talking to you about. This is the pulse we get on the tens after we relax muscles and decondition them, and at the initial part of the treatment. And we see that what is happening here is that the mandible wants to come forward at least 1 millimeter on that occlusal plane. Plus, we need another 3 or 4 millimeters maybe for the lower arch in order to align it correctly. So we're looking at an overjet we need of about 4 to 5 millimeters. That's why we need rapid palatal expansion. That's why we need a little bit of lower distalization. And that is exactly what is going on. For that reason, what we can see what is going on through the kinesiography. But as I promised you, I was going to show you something else. And this is the same sagittal frontal view of a swallow. This is a spontaneous swallow of saliva, SSS, as we call it in jargon. And you can see it now. Okay. This is just, his patient is relaxing here, and we're just waiting till the patient swallows. Then the patient swallows, hits the incisor, because it hits the incisor, and then we ask him to tap in central occlusion, tap in central occlusion. And what we're seeing here is that the direction, the patient starts to swallow and hits the incisor and then reaccommodates the central occlusion. This path of closure here, which is driven by the spontaneous swallow of saliva, gives you about 2 millimeters off centric occlusion, which is the demonstration that the subcortical systems in spontaneous swallow of saliva already give you what is a neurophysiological trajectory to occlusion. I know this was a little concentrated. I hope you enjoyed this presentation, but in order to completely describe the application of these principles to neuromuscular orthodontics, actually a little bit more time is needed. And I think I am just right. At 40 minutes, they told me 45. So if you have any questions, I still have 5 minutes for you. Thank you very much.